enter, so now we can begin. Now that he's a fellow, you have to give him even more authority and deference than merely as a physician, as a director. Good afternoon, everyone. My name's Chris Kohler. I'm the president of the Milbank Memorial Fund, and it's my privilege to have the last panel tonight. By the way, or this afternoon. By the way, Mark, I think you need to double Cliff's appearance fees. He did yeoman's work today, carrying 2 panels, and did a great job. So I will try to. You did a kinder, gentler version of Wolf Blitzer in sort of keeping things going here. So I will try to follow in your footsteps. We're about states this afternoon, and I think as we've gone through the day, those of you who are veterans of this conversation, I was struck, perhaps you were too, by the evolution of the conversation. It is getting more sophisticated all the time. It used to be that we would beat up Mark to say, what the heck does VBID mean? How can you get any more general than VBID? There was talk about whether you need to be more specific. But you're seeing more sophistication in terms of the tools that are available and how people use it. And what we're doing here, I think, is closing with the states because in a lot of ways, this is where a lot of the theory hits the practice in the states, particularly given the roles that states have. And I want to just sort of, when we talk about states and what they're doing in relation to VBID, I want to note that states occupy a bunch of different roles in the healthcare conversation. They are the buyer. They run consumer protection interests. I should go back. When they buy for state employees. They buy for Medicaid. They might buy for locals and municipals. They have a fundamental statutory obligation to protect the most vulnerable in the population. They ensure public safety and public health. They have, in some cases, taken on the responsibility of running these new things called insurance exchanges. And more generally, they're the people that are held accountable. When the wheels go off, you generally end up calling someone in the state. You call your Surgeon General, you call your Medicaid director, you call your legislator and say, fix it. You don't try venturing into CMS. And I can't tell you when I was health insurance commissioner how many times I got calls from self-insured folks who were looking for some sort of relief and they really didn't want to deal with their HR department. So the states have that kind of responsibility. The states operate with a number of realities when they're trying to carry out these roles. Though in no particular order, they've got to deal with multiple different payers. So if you talk to a provider, one of the benefits and the banes of the system we've got are all these different payers who need to be coordinated. So no single payment reform works. They work in a world of constrained resources. They work in a world where we know what will improve population health, but we're compelled to do stuff for individual folks. And where we know, we've seen the diagrams and we know that stuff to improve population health has very little to do with the medical care system. But our Medicaid budgets are draining us. They work in a world where if healthcare goes up 5% and it's 30% of the state budget, that does not give you any more money to pay for anything else if your constituents don't want to pay tax increases. Nothing for salaries, nothing for pensions, nothing for roads, for schools, for anything else. I think they work, I would say the last thing they work is an inherently political world where there is conflicting notions of what is the public good, and it's up to some sort of messed up state process, which we hate until we need it, to determine what the public good is, whether it's on the executive branch side or on the legislative branch side. So you can tell I'm kind of into the role of the states. Few events when they're trying to deal with these realities. You've got discussions around what to do with your Medicaid populations and Medicaid expansion. You've got issues of sustainability of the Medicaid program and duals. You have new responsibilities at the states for commercial market reforms and dealing with exchanges. Oh, and by the way, the feds are showing up with possibly hundreds of millions of dollars for state innovation model grants, if you have any idea of what you want to do with it. And you can deal with the numerous webinars that come with those responsibilities when you get those SIM grants. So it's a great time to be working on these sorts of issues if you can deal with the kind of environment that these folks have to work with. So our task today, our challenge is to sort of say, okay, you've got these laboratories of innovation. You have incredible variation. In my job at the fund, we work with very different states. It's like a lesson in federalism, and it's a lesson in variation. What works in Vermont what works in the People's Republic of Vermont will not work in Oklahoma, and you've got to accept that. I mean, and you've got to come up with solutions that work locally. So we're going to hear how states are taking this evolving information about engaging consumers in these questions of reducing some of the waste. That was a great last panel that we had. And how it's actually being applied, sometimes with consumers, but actually sometimes with providers. It's a great panel that Mark and his folks have put together. I had our batting order. Yes, we're going down this way. So we're starting with Joe Thompson, who is Surgeon General, policy entrepreneur. He keeps his crew. He was telling a story about where he was on Friday when he didn't have to talk about Ebola, but then he did have to talk about Ebola. So he's a ringleader.
Is this an Ebola conference?
No. Two things that are out of bounds, Ebola and Medicaid expansion. We have our hands full talking about other things. And if we talk about either of those, then we mess up Mark's value proposition for VBID, bipartisan, bicameral. So we can't talk about those things here because Mark wants political consensus around this. So it's all about value. Next we've got Lori Lee, who's going to talk about efforts to engage state employees and more broadly public employees. States have enormous opportunity to set the agenda, not just for state employees, but for other municipalities in the states that are buying health insurance. And then we're going to hear from Kathleen Nolan from National Association of Medicaid Directors with a perspective about what's going on across all the states within the Medicaid program. Joe.
Well, thank you for inviting me. This is my first time here, Mark. Thank you for the invitation. This may be my last invitation here, but we'll see. No, truth in advertising. I am a pediatrician. I'm in the College of Medicine of the University of Arkansas for 15 years, 13 years. We've run a health policy unit, the Arkansas Center for Health Improvement. For 9 of those years, 2 governors have bought 50% of my time to be their lead cabinet level advisor on health. There are 3 states that have a Surgeon General. You're the second, Michigan. It's inside of your health department, runs programs for your health department. The third is Florida, which is the same as their DHS commissioner. So that's the background on where I come from. 7 years ago, in the middle of the economic downturn, in my monthly or bi-monthly briefing with the governor, when state revenues were flat, insurance costs were still nearing double digits, and we had a little bit of a problem. Now, my governor has been a 30-year member of the General Assembly, 1-term Attorney General. He's in his 2nd term as governor, 10 years, 15 years on hospital boards. He goes, Joe, what's the problem? Why are we in this fix? And I said, because we're based on volume-based fee-for-service medicine. I don't care how it's packaged. That's what's there. And he goes, well, fix it. I said, okay, we'll try to fix it. We started a transformation effort to try to extract more value from the money that we were putting into the system. Candidly, it was out of a crisis, an economic crisis that was hitting both the public and the private sector. 4 parts. We'll only touch one today, but workforce development. We didn't have a strategic plan for our workforce despite having 22 higher education institutions across the state. Electronic health information, which we've heard today, is an opportunity but a challenge along the path. Insurance expansion, which I won't use the word, but we are the only red southern state that has actually found a way to utilize resources recently made available by an unknown source. And then the third, and actually this predated the Affordable Care Act, which I think is part of why we were politically able to take advantage of it, was to take on total system transformation of the way we paid. I had the opportunity to be in different circles with our Medicaid director in some of the challenges that they were having, with 2 of our larger commercial carriers and the challenges that they were having. The challenges were the same. Medicaid didn't have enough general revenue coming in. The private carriers were losing premiums because their employers and individuals were not able to afford continuing double-digit increases in prices. Totally different languages, totally different systems, but we brought them together, and actually the governor came out and said, in 5 years, we're going to change 70 to 80% of the way all health care is paid for in the state of Arkansas. 5 years. During his legacy, 5 years. We started a payment transformation effort that is, at its core, has kind of three components. One is that we needed every payer to be pulling or pushing with the same incentives on the provider system. We'd had for 20 years Blue Cross doing one thing and Medicaid doing a different thing and QualChoice doing a third thing, and who knew what Medicare was going to do. So we needed a single set of incentives on the providers. The second, and this is what was enlightening for me as a provider, I saw both Medicaid and the commercial carriers put up the white flag and say, we're not going to try to micromanage the providers anymore. We're going to try to get rid of as much pre-authorization, as much pre-approval effort, but we need a local clinical provider to be the quarterback of the team and to be in charge. So we put forth a three-part effort on payment transformation, and I'll give you an update on where we are in just a couple of minutes, but let me give you the three parts. First, and at its core, is the patient-centered medical home, team-based, not limited under the roof of the primary care provider, but a team of people, can include the pharmacist, the mental health provider, the nurse practitioner, the school nurse, a team, and assign individuals to that team, and that team, led by a physician, has upfront per member per month payments to put infrastructure in place, averages about $5 per attributed member per month. But their real money is in their guaranteed 50% shared savings out of the total cost of care for the patient if they hit quality indicators that are pretty high along the mark and they make transformation efforts. Transformation efforts of same-day appointments, 24/7 telephone access, on an electronic record in 6 months, top 10% sickest patients identified and seen in 12. Second year, they're seen twice. They're connected to the information exchange by the end of 24 months. All of those are milestones with quality indicators, and in the second year, that team can start to have shared savings from eliminating some of the 30% of waste or the improvement in outcomes that was been described earlier today.
And that's across all payers.
We have Medicare in a limited way through our comprehensive primary care initiative, Medicaid, Blue Cross, Blue Choice, the three largest public employees, the public self-insured employees, state employees, public school employees, and the university. And we have had Walmart corporate buy on because they see it as a value add to what they were doing inside of their corporation. And they're our largest private sector self-insured company. So those are all of the payers that we now have working together in this same manner. So patient-centered medical homes, upside, gain sharing only for the team getting the best outcome long-term for the patient. Separately, when there is an investment in an acute medical care need or a high investment for a complex patient, we want a quarterback in charge of that episode too. So we started off with 5. Hip and knee replacement, actually it's 9, but I'll describe 5. Hip and knee replacements, pregnancy, upper respiratory infection, so an acute condition with lots of providers, attention deficit disorder, simple attention deficit disorder in kids, so a mental health condition. And the 5th was one that Medicare had done, congestive heart failure readmissions. We assigned a quarterback for each of those 5 conditions and defined a time period that they were responsible. For hip and knees, it's 30 days before to 90 days after the surgery. The orthopedic surgeon's responsible. Everybody gets paid along the way, but the orthopedic surgeon has upside and downside risk for both quality and financial indicators on how they do. So if, as an orthopedic surgeon, I reach upstream and have fewer images that are unnecessary, if, as an orthopedic surgeon, I make sure my hospital has a low infection rate, if I make sure the DVT prophylaxis was done so they don't have the pulmonary embolus, if I make sure I get them to the best physical therapist so they're back on their feet downstream, and if I make sure we don't have a reoperation, I'm going to get paid more. If I don't do those things, Medicaid, all of our self-insureds, Blue Cross, QualChoice are going to claw money back from my payment. So the episodes have upside, downside risk. Those were our first 5. We've extended that to now include cholecystectomy, gallbladder surgery, tonsillectomy, colonoscopy. We're going live with asthma, stents, open heart surgery this fall. We've got 6 neonatal episodes. And again, our goal here, these are the big ticket, high volume items. Now we have patient-centered medical home, now episodes launched across multiple payers in the state. Finally, a third group, which I won't mention much of, but we have several folks that have severe needs, so the severe and persistently mentally ill, the frail elderly, the developmentally disabled, that it's not just their medical needs, but they have social needs. So we build a health home around their needs in partnership with the healthcare team, but with the social support network. So we launched this 5 years ago. We did our first payouts and clawbacks on episodes in January of this year across the top 5 episodes. We have about 6,500 physicians statewide. We have about 2,000 that were affected by an episode. We processed over 250 million episodes to generate the reports that went for the payouts and the clawbacks on these physicians on the episodes. We ended up paying out about to 250 physicians an extra payment. We ended up clawing back from about 300 some of the payments they had been paid. 90% of the clawbacks wrote a check in the first month and said, yeah, I didn't hit the mark. I see how I can do it in the future. And they came in and they looked at the data. We're giving them quarterly reports on all the data, not with the Milliman charge that we heard earlier, free reports on here's your profile for the 120 days of experience, total experience, everybody that touched your patient, who they touched, what they did, what they cost. A patient-centered medical home space, we now have 70% of our Medicaid beneficiaries under a shared savings model, with the first shared savings being eligible starting July of this year. I'm going to close it out real quickly, but in our unmentioned expansion from unknown sources of money through the private sector, we made a requirement of that all of those insurance carriers must participate in our patient-centered medical home shared savings model. So QualChoice, Blue Cross, and Centene will join the state employees, the public school employees, and Walmart in reinforcing the patient-centered medical home model that Medicaid has already put out. Now, up to this is all payment transformation with a little bit of workforce development, electronic health records, and expansion of insurance coverage. Tying it to the value-based proposition. I'm concerned you're not going to get to value-based proposition until you have harmony in the signals that are being sent into the provider market, and you have harmony to the signals that are being sent to the consumers. Upper respiratory infection was one of our first episodes. We dropped the unnecessary use of antibiotics by over 25% in 12 months because every provider was getting the same signal, and therefore every consumer had the same educational effort underway of why they didn't need the antibiotic. We increased the screenings in obstetrics. We dropped early prenatal C-sections in obstetrics. One of the commercial carriers reports a 3% drop in their hip and knee surgery cost, episode cost, not the surgery, the whole 120 days. We have one of our 4-person orthopedic surgery units has switched hospitals because the hospital wouldn't move with them on a value-based proposition going forward. So I think harmony is needed in the signals to the provider and to the consumer market. And now what we're having is real value-based conversations of, particularly on our commercial carriers, can they vary co-payments for the individuals based upon, number one, you'd get a lower co-payment if you picked a primary care provider. Too many of our commercial enrolled individuals aren't required to pick a primary care provider because the commercial carriers are scared to get death. They're going to be labeled gatekeepers again like they were 20 years ago. So we'll put an incentive. If you pick a primary care provider, it's a lower co-payment. If you pick one of our patient-centered medical homes, it's a lower co-payment still. And when we actually start having shared savings, I think there'll be a third tier that if you pick a patient-centered medical homes who has demonstrated high quality, more efficient, lower cost care, you, the individual, have yet a lower co-payment inside of the same carrier structure across multiple carriers. So that's our story. I'm sticking to it. So far, our providers have not revolted. Our carriers and our payers have stuck. We're recruiting additional carriers moving forward. Medicare has not agreed to expand their footprint because Medicare does upside gain sharing only in their models unless you're a capitated system willing to take on risks. Our episodes are upside and downside. If you don't do well on our episode, you're going to owe money back. If you do well, you're going to get an extra paycheck on top of what the team got paid. So with that, let me pause and look forward to questions and answers.
Great, thank you. Okay, Lori, public employees. When I was a state official, we didn't call our benefit insurance, we called it Blue Cross. I got my Blue Cross, I might as well use it. The chair of the Blue Cross board was the head of the local AFL-CIO. The process was somewhat wired in the bidding process. Needless to say, when it went out for RFP and Blue Cross didn't get it, they were somewhat surprised and took it to court. So the job of public employee benefits purchasers is not always easy. So tell us some of your stories.
It's not that bad. That sounds terrible. So, Mark, thank you for including me. Mark had asked me to talk about some of the things we've done with consumer engagement, and I act like any other purchaser. So I act like any other self-funded plan. We do manage plans for about 275,000 lives in Tennessee, and so that includes state employees, higher education employees, local education, as well as some local municipalities and governments, their retirees and dependents. So you roll all that up, and that's just under 1 out of every 10 commercial life in Tennessee. We have always had competitive procurements where we have at least one, we cannot just have one bidder. So we've always had more than Blue Cross. We've always had Blue Cross at the table, but we've always had at least one other commercial carrier. So what we did about, and gosh, what you were saying, Joe, sounded so familiar. You never let a good crisis go to waste. And so when the budget was tanking, when the economy was tanking, I had just taken on my responsibility in managing these plans. And right before the economy, the bottom fell out, I had taken sort of a ground-up look at the plans, and they were all performing equally poorly. And so I decided we needed to kind of start from scratch. And then the bottom fell out, and the budget was, we were $1 billion short in terms of the budget. So it was a great opportunity to push through a lot of change in our benefit design. So with that, we implemented two major changes. One was just purely around purchasing, and some of the things that we've heard today earlier. I mean, per unit cost gets you a great, bang one time, and then, whew, the rate still continues to increase. But at the time, that's what we needed, and we needed a big drop in cost immediately. So we carved out our pharmacy, we carved out care management, which for us includes disease management, lifestyle management, wellness program. We had already carved out BHO, and our intent there was to get best pricing and best in class. And just from purchasing alone, we procured everything. Just from purchasing alone, we were able to achieve about $750 million in savings over 5 years from our previous, as compared with our previous contracts. We had sent a really strong message to the marketplace with these procurements that we were looking for price, because that was the emergency, that was a crisis we were facing. So we did the purchasing. We did some other things, just I think most plan managers have done in terms of dependent eligibility verification. Tossed off a lot of people that just then came back on with the ACA when the college kids could come back on the parents' plan. So we threw some of them off, and then we put some of them back on. So we tightened up subrogation, duplicate claims analysis. We were looking for every penny of savings. So that was just purely on the cost side. The other thing we did was implement 2 new benefit designs, and we really simplified and just went with 2 PPOs. And prior, we had 3 different plan structures. Two-thirds of our members were in plans that had no deductible. So, they were very, very insulated from the idea of cost. So we put in 2 PPOs with modest deductibles, but with, you would have thought we had, done the evil thing because we took away their plan and implemented a deductible. But one plan is oriented around wellness and consumer engagement. And that plan we call the Partnership PPO. For that plan, members pledge to engage in their health and wellness. And for that pledge, they receive lower premiums and as well as lower cost sharing across the board in terms of lower copays, better coinsurance, and so forth. Our aim over time was to increase not just awareness, but actual engagement, so that people connected that the decisions they made about their own personal health ultimately has an impact on cost. Try to make that connection. The other thing we did with the procurement was, with the 2 carriers that resulted from the procurement, we put a surcharge on the more costly carrier. We did that procurement by region, and the price for Tennessee, if y'all don't know the Tennessee geography, we are a very long state. And in fact, it's actually farther from Memphis to the other end of the state than it is from Nashville to Canada. So it's very large, very different markets across the state. So we procured our contracts regionally by 3 divisions because we could get better pricing. So we put a surcharge on the carrier that had the more costly pricing. Again, what we're trying to signal to our members is pay attention. Networks have, your choices have consequences, and those of you that have ever raised a child, you're always saying that, right? Bad choice, it has a consequence. Well, that's what we were trying to say to our members is pay attention, your choices have consequences, both in terms of the network you choose and the decisions you make for your personal health. So that was the early messaging, just trying to get that message out. The people got the first message, which was, woo, I can save money by going in the partnership PPO. We had great take-up in that PPO, about 80%. They missed the other part, which was you have to do something. You can't just get the benefit of that lower price without engaging. So when the engagement piece came around, wow, did we get a lot of, wait, you mean I have to complete a health risk assessment? Wait, you mean I have to go to my doctor and get a biometric test? No, let me tell you, we actually procured a communications professional to help us with this communication strategy, and they still missed the message. So, and a lot of concern about Big Brother and what are you doing with my data, and why are you making me do this, and so on. So fast forward, so that was in 2011. We implemented those 2 plans. So we have a few years of history now, and we are actually getting some really good results on things like adherence to preventive measures, preventive testing. Our HEDIS scores are terrific for those in the partnership plan, and dramatically different for those who are not or who chose the other plan. Our utilization rates are better for those in the partnership plan, emergency department, for example, ER use. I can give you, someone said, if I had a slide, I could show you those statistics. But really some good results. So I think we're doing the right thing. It doesn't necessarily save us money. So we haven't seen that those efforts are saving us money. I think we're spending it on the right thing. We're spending on more primary care office visits than the emergency department, and there are other statistics like that show that we are, I think, spending our dollar better, but it's not overall, so far has not shown demonstrated results of savings. So back to consumer engagement. We've learned a few things. One is people do pay attention to cost, and they are sensitive to price. But I mean, the other thing we've learned is they really don't go beyond that, at least so far. So I was thinking about what Marge was describing, and a 4-hour conversation, a focus group conversation with people about this really complex issue. And at the end of that, light bulbs are going off, and people are kind of connecting with, wow, I could make this choice versus that choice. We don't have that luxury. When we're communicating to our members, we're lucky if they don't circular file what we send or electronically, delete. So, that communication piece and breaking through to the consumer is so challenging. So where we are now is our first year, we had about 80% sign up for the partnership PPO, and 90% of those completed their agreement, if you will. So we had some attrition. If you don't complete your agreement, you're defaulted to the standard plan where there's higher cost sharing. You're sort of in timeout, if you will, for a year. You can come back in, and you can re-up and try it again, and hopefully, maybe you've learned your lesson and you're in timeout. And so we have had some people come back into the partnership plan. And again, we do have some good evidence in terms of preventive measures, but not overall cost savings. So where we're going with this in terms of next steps is we're continuing to evaluate what's working with that plan, what's not. We're about a year, actually almost 2 years behind what Arkansas is doing on payment reform. And what I'm looking at is the patient-centered medical home and the ability to maybe use some of the resources that we have been spending on some of the disease management efforts, diverted more in the medical practice site, because I think that's going to be more effective. We're also looking at a very effective program that the CDC has around diabetes prevention, the diabetes prevention program, if some of you've looked into that. Our big problem, no pun intended, is obesity. So diabetes prevention is really geared around weight, nutrition, physical activity. I think has a lot of promise for our population. Our challenges are scale. So anybody who's running a big statewide program, just our geographic scale, we're in every county. So being able to have a turnkey program around health and wellness, for example, is hard for us to do across the state, but we're looking at that. The other challenges is just really breaking through to our members, and I think the medical literacy, if I can use that term, we speak about financial literacy now with so many more efforts to make people accountable for their own spending, whether it's in investments, whether it's on the pension side or now on the healthcare side. The medical literacy level is so low, and it's very, very hard to break through. So just trying to increase the knowledge and understanding with our members. We're also looking at department-level strategies. So one of the great benefits of what we've done is we have a huge data warehouse of some very rich data now that we can slice and dice by departments. And so we can look at, for example, our Department of Corrections. And it's probably not a surprise, but that's the highest failure rate of completion. So we have more defaults of people, not completing the partnership wellness program, and high rates of chronic disease, high rates of ER use. I mean, it's just prime for a really targeted intervention. We have an employee health clinic that also has now the capability of going out remotely to areas across the state. So that's one of the things that we're looking at is can we implement some very targeted interventions that are built around a department or a geography or geographic hotspot. So in terms of value-based benefit design, we did incorporate some, I would say, just the baby steps in terms of VBID when we launched our new benefit design, particularly around chronic disease co-pays on drugs. Mark and I have had this conversation. We've just sort of put our toe in the water. I think there is some additional potential with our population, but right now working on the payment reform and the next iteration of our consumer plan, we're kind of trying to see where all of these things fit together. So I would say it's not for the faint of heart. After the break, if anybody wants to know what that means, I'll tell you, because we've had really some hateful conversations with some of our members by email, by phone, who, honest to goodness, just think that this plan is evil. that we are, as I said, Big Brother and the black helicopter coming in to do something bad to them. And so just getting over that fear, helping them to understand this is really about helping to provide tools and resources for them, and ultimately to ensure that we have a sustainable benefit in the future is still a challenge. There's some great success stories too, but it's heavy lifting.
Okay, so we've got parental images and Black Hawk images. Yeah. We can right. Hang that in head. All right, Kathleen, consumer engagement in Medicaid. Null set? Overlap? What's it look
really like? That's a really good question. And thanks for everybody for lasting this long and now talking about Medicaid, because normally if you've been asked to delve into Medicaid in your arenas lately, you've probably rolled your eyes and said, oh my God, you got to be kidding me, right? So thanks for lasting this long. So I want to talk a little bit, and as you said, Chris, the center of innovation right now is the state level. And this is where a lot of this work is going on. And when you're talking about states, you can't ignore Medicaid. That's just the bottom line. In every state, it's growing, expansion, non-expansion. They don't like to be called non-expansion states because their Medicaid program is growing in dollars, in people, you name it. So this is a very necessary conversation to be having in Medicaid. So Mark has been coming to talk to me for a while now and trying to get me to come out here because one of the things he's been saying is, can you do VBID in Medicaid? And my answer has consistently been, in the strictest sense, no. A lot of the benefit design context and a lot of the consumer engagement tools are not available or not viable in the Medicaid arena. But before you pack up your stuff, I want to talk a little bit more about what is possible and what is going on right now in Medicaid that's worth engaging in this conversation. We are a growing program. And we don't talk so much about whether we have to sustain this program. This program is going to be around, and if we don't get better at it, then we're not going to be here. We're not going to be able to continue to provide the Medicaid program. So the conversations in Medicaid are very much around how do we engage consumers? How do we engage providers? How do we get better at value? And I know there's some weight in the value word, but value, when it comes to a public dollar for a public good, is the conversation that's happening in Medicaid right now. Are we getting the maximum bang for our buck because we're putting a lot of money out there? So this is the conversation in Medicaid, which is the conversation that's been happening here for the entire day. And so I think there's a lot of synergies between what's going on in Medicaid and what's going on with other payers and with the healthcare community overall. But you have to recognize from the beginning that Medicaid is different. It is different for a couple of reasons. One is the people in Medicaid are a different group. They are in different places in their lives than the vast majority of the commercial market. They have high needs, but they're often the people that a lot of these conversations have been talking about. Chronically ill folks whose decisions about what health care they get are the definition of whether they'll be able to continue to work or to take care of their families or other things. So they're a really important population, but they're different. Federal, state conversations. We've been talking a lot about bipartisan, bicameral. Now we have to get consensus, political consensus, between the state level and the federal level. I don't know if anybody's really played in that arena much, but this is really hard. Medicaid is half funded by the federal level and half by states. That means everything in Medicaid has to be agreed upon by those two entities. They have to both like it. And so there's a lot of dichotomy and a lot of variation in the conversations that are happening and what states want to do with Medicaid and what the federal government wants to do with Medicaid. So I think that one of the things that I was asked to talk about is what are the challenges in engaging with Medicaid in this conversation? And I think that's kind of the first one. The signals that we've been talking about, particularly from CMMI at the federal level, is an interest in these concepts around value and low value, high value, and making some of those distinctions. Most of that has been from CMMI, which doesn't make decisions about Medicaid or about Medicare specifically on a gross cross-program basis. They make decisions on demonstration projects and pilot projects and grants. But when it comes to systemic change in the Medicaid program, it's the Medicaid office at CMS. And to date, there hasn't been as much interest in engaging in the kinds of conversations that we've been having here today in the Medicaid program. And we can talk some more about what's viable, what are some of the things that we've been thinking about, and I'll talk a little bit more about those as well. So I think the federal acceptance is one issue. Advocates has come up a little bit when we were talking on the last panel about sort of the public perception. But when it comes to the Medicaid program, and you talked about your own employees not liking it, when we can't get something through the advocate community, it's not going to happen in Medicaid. And the advocate community is very involved in Medicaid decisions. And so public comprehension of changes like this is intensely important when you want to try something like this in Medicaid. So I really think that that's a conversation and how people understand and what the impact will be on choice and on access, because access is the underpinning of what we're trying to do in Medicaid. It's not create an efficient insurance program. It's to give access to poor people to care, and that's really what we're trying to do. And so I really think that's an issue. And then I think the other concern, and it was referenced earlier, is this issue around how do we know what's happening once we put things like this in place? And so beyond trying to frame what will be acceptable and how to frame a value-based purchasing situation in Medicaid, we have to have the data to know what's happening and to know what's working. The providers need that data. The Medicaid agencies need that data. So that's another component that I think stands in our way, is we don't do as well as we could in the data conversation. So in Medicaid, what are some of the things that are going on that relate to some of your own efforts to drive value-based insurance design, VBID, or other related concepts in Medicaid? We are talking about clinical protocols. Clinically nuanced approaches are coming into place in Medicaid, and we did briefly mention hepatitis C, drugs and treatments earlier. That's a place where a lot of states are saying, okay, we have to cover it, but can we do this in a way that works for us better? Value-based purchasing, and both for care, like an ACO type of model, and value-based purchasing for managed care, for plans. A lot of states have always have had a lot of managed care, but they don't necessarily competitively contract for those plans. It's any willing plan. And so a lot of states are trying to take a look at how they could purchase insurance in a much more proactive and strategic way. And so I do think that's another theme that's been going on here that very much fits with the movement within Medicaid. We do have a lot of ACO-like models, a lot of care coordination models that have components and elements that we've been talking about here today happening in Medicaid. And how can Medicaid interact with some of the principles in value-based design, I think, is another key piece. But it's not, I'm still struggling to make some of the connections, and maybe we can talk about that in the Q&A portion, about how we drive the accountability for value with the provider community, because I don't think we've really got there yet today. But I do think that that's a more important conversation in Medicaid than driving value with consumers. And then the last thing is, there are a number of states who are looking at, and I'm not talking about whether they expanded or not, but their expansion population as a place to try new things, because there is a little bit of flexibility with this subgroup in Medicaid to be able to try out some skin in the game for consumers, to be able to purchase more closely designed benefit packages, since many of the folks maybe in an expansion population have behavioral health needs. Can we design an insurance package for this population that really tackles that issue in a different way? So there is some opportunity to do some experimentation in the expansion group with those adults. But I think the biggest challenge is, and is a little bit around innovation fatigue. And I think that that's not something that has come up yet today. But we hear this a lot from folks, is everybody walking in the idea. This came up in a meeting last week with some Medicaid directors. Everybody walks in my door every week and says, I can help you reform your Medicaid program. You just hand it over to me and you're going to have the... Sorting through the opportunities, and I'll put that in quote, the opportunities for reform is really challenging. And so I think that as each of you approach your own environments, what are we really going to be able to do? And I think that having a conversation with a Medicaid director that says, well, if we had perfect data and we had electronic health records and the providers were bought in, we could do this tomorrow. But we don't have any of those three things. So, I really think there's got to be a strategic conversation about where we go with the innovation pile-on that at some point, I'm not sure we're going to be able to say that we've been successful in some of these without some of that strategic conversation. So, bottom line, Medicaid is all about delivery system and payment reform. There are limits and differences to the way that we can work on those issues in the Medicaid environment compared to a commercial or other payer markets or to Medicare. It is going to be different, But I do think that overall the appetite is very strong in Medicaid for tackling the issues that have brought us to this place. The crisis that has brought us here, we all recognize it in Medicaid, and we know we have to do our business differently. And agencies are really preparing to take on those new challenges. And what is the role that a lot of the themes that we've been talking here today is going to have in Medicaid reform, I think remains a question that I have and a lot of other people have is can we do this? Can we achieve some of the things that we've been talking about today in Medicaid? And we'll just have to see.
Great. So I want to throw out a few questions and then throw it open to the audience. I'm actually going to go to Kathleen just because you've kind of teed it up, and I don't give you just a moment to catch your breath.
Sure.
But as some of the states have looked at those expansion populations, there have been some pretty heavy-duty negotiations with the feds around benefit design. Ability to, some of them seem like, and could you characterize for the audience to what extent they're simply efforts at cost sharing? Their efforts at enforcing virtue. You can do the right thing, and we'll let you partake. The mother may I kind of, as opposed to being in timeout. And to what extent they are what would fit the definition of value-based insurance design.
So the vast majority of expansions look similar to the Medicaid program, just to the new population. So in most of your states, if you're an expansion state, you took your Medicaid program and you just made these folks eligible for it, and it didn't really change. There are a handful of states that said we want to do something different. Some of those involved things like copays. Some of them involved incentives or other types of efforts, or fill out your health risk assessment and we'll put aside money for you to draw down later to pay premiums in future years. There's some really interesting experimentation that's being considered. How far we're going to be able to implement those, how much federal acceptance there is going to be, I think remains a negotiation factor. So Healthy Michigan has a number of components in it that look like this, but most of those aren't to be implemented yet, and it's still going to be the devil's in the details. So the vast majority, it's pretty straightforward, and a few, there are some efforts to try, not finely tuned, but a few bigger features of insurance design that fit this mold.
Could I just add, in our negotiations, and I think, correct me if you think this is wrong, but I don't think the federal government is going to allow copayments to be a barrier to the receipt of service for anybody under 100% of poverty. Ever. Now, having said that, I have special language that requires me to put copayments on people down to 50% of the poverty level, or the program goes away in January. Right?
Right.
So we're going to put copayments on people, but they're not going to pay, and they're going to accumulate a debt to the state that at this point in time we're not going to collect.
That's why it's great to be a state worker.
So they will have copayments. Sorry, they will have copayments. They will receive their service, and they'll have a debt to the state for the next governor to decide how aggressively he wants to pursue. So I would just say, I think in terms of the value-based benefit design, that is the one strong line in the sand that the feds have said, is that cost sharing as a condition of receipt of service at the point of service below 100% is not an option.
And I think that's where it would be really interesting. Medicaid folks are different. They are lower income. They're more vulnerable in other areas. And I think that there isn't a conviction yet from the federal level that we can still have access. And I think their goal is access. Their only goal is access. It isn't cost containment. It isn't high value versus low value. It's access. And so anything that looks like an access constraint is really challenging.
Different question. Start with Joe, but then Lori, you might want to chime in as well. When I've talked about state efforts, especially to private sector folks, I've said the state is the place to do payment reform because the state has Medicaid, it has some state employees, it can jawbone the commercial insurers. But the private sector is the place to do benefit design innovation. You have to learn from we have to learn we, the public sector, have learned from the private sector about benefit design, but you have to learn from us about payment reform, and particularly around alignment, the efforts that you're describing. So agree or disagree with that statement. Talk a little bit particularly about engaging self-insured, because they're half of the commercial spend, and you only have your charm and good looks to try to get them to the table to do what you want them to do.
So you have to split the self-insured, I think, in your mind between those that are state-based, state employees, public school employees, your university system, and those large self-insureds that are multi-state. A multi-state entity is difficult to get committed to doing a state-specific reform. They're managing people across all 50 states or the whole world, and so they got to have benefit consistency. They will do it. They'll have a demonstration project. They'll do it, but it's a harder sell. So I would say with the self-insured, identify whether the entity is state-based or predominantly state-based. It can be a commercial entity that has most of their employees within your state. They will be very interested in trying something new. Your multi-state self-insureds will have a harder time getting to a yes. Your public self-insureds that are state-contained are looking for opportunities to add value and to contain costs.
And are you guys going to lead with that, or are you going to jump on a statewide bandwagon?
So our market's a little bit different from Arkansas. We have so we have a major carrier, Blue Cross, that has a little over a third of the lives. But we also have a big presence with United and Cigna, Aetna, and other carriers. So one of the things that we did in our payment reform initiative was our Medicaid program, in their contracts with the MCOs that they contract, with whom they contract, and that's United, Blue Cross, and Amerigroup, they required those carriers to participate in payment reform in their commercial space. Mm-hmm. That is built into their Medicaid contract, that they must, on the commercial side, participate. My contract, and I'm coming up for a next contract cycle, will require the same. So anybody who bids on my business. So we're able to leverage our purchasing power, not just for the lives that we cover, but for those that are engaged with us on the other side.
She triggered something that has evolved. At first, our multi-state self-insured companies did not participate on episodes because there was upside-downside risk across different groups. Mm-hmm. Their carrier has now extended it as a condition of participation for all of their self-insured. So, so one of our two commercial carriers, the episodes is part of the contract for both the fully and the self-insured because after a little bit of experience, they had something to be able to show the self-insured why it was making a quality impact or a cost impact on the system. Mm-hmm.
Just one other thing I'd like to add, and we have two business coalitions in the state. We are working, and I'm a member of both and have been for a long time, way before the Payment Reform Initiative. They have been very interested in engaging with us and engaging their members, their large self-funded employers, as well as those that have fully insured products in this. And in fact, we've got a meeting set up at the end of the year to really elevate the initiative with those two groups. So we're reaching out to the private sector. The other question was about benefit design, and for us, we have acted like any other private sector employer, for several years. when I came on board, I said we are not going to do business as usual. So I have deliberately engaged with my counterparts in the private sector to learn what they're doing and to borrow some of those ideas. And I hope it goes both ways.
So I have a fact-based question, and then I want a general, and then we'll throw it out. The fact is, particularly for Arkansas and Tennessee, did either of you need new statutory authority to do the payment reform or the benefit design activities you're requiring, or was this done within your existing authority?
We did not require any statutory changes. And on the public sector plans that I administer, there are some constraints in statute that I wish were not there, but I've been able to work around those.
We didn't require statutory authority. We required regulatory rulemaking for Medicaid to change the way that they paid providers.
Right. So in some states, they do a big statutory payment reform.
Right.
So my last question for you guys is The role of, to what extent, as you've looked at these innovation fatigue, let's talk about this innovation fatigue in two ways. To what extent are you just firing at what comes along, and to what extent are your decisions based on health services research produced by Dr. Chernu and Dr. Ayanin, where you consult the evidence, it is there, it's published, and you use it to convince, as opposed to, that sounds like a pretty good idea, let's go try that. And whether you use that or not, what are your resources to do this work? If healthcare is gobbling up the entire part of the state budget, are you like, how much you burn the midnight oil? How are you getting this stuff done?
So, I have a 35-person policy shop that largely has to generate its own money from contracts, grants, and external resources. Some of those supported by state Medicaid, some of those private philanthropic grants, most of those tied to real work that we try to carve a little bit of space off to do thinking from. I think the model that we have is one that we have advocated for others to think about in state government, in that all of my state governmental cabinet colleagues are running huge programs. I mean, a good day for John Seelig, our Department of Human Services administrator that has 13 divisions, only one of which is Medicaid, is if at the youth services centers across the state nobody got backed over by a bus.
Yep.
I mean, that's a good day. The program management for agency heads is overwhelming, and they don't get to think strategically. So I think a lot of states, it is whack-a-mole compared to the previous effort. We've had the luxury of having some space and time to be able to try to position what we could see coming, whether it was a crisis or an opportunity, to be prepared to use it. But I think it's crisis or opportunity preparedness more than anything.
We do not have a think tank. We have a very small staff. So my directors who manage the various programs are their own researchers, and it really is, it's really tapping our resources. Now, some of the things, we'll look at evidence that, particularly around behavior change, that looks conflicting. So, how do you implement a program when some of the evidence is still emerging? And so we're partly trying some things out and then measuring and being very nimble to say if it's not working, we're going to stop doing it and do something else. So we could use some more resources. I'll put it that way. It is challenging. I mentioned the diabetes prevention program. That has a long,
right. That's been very well tested.
Very well tested, good track record. We have a pilot right now in our population, and that's working pretty well. And I'm looking to see how I might be able to scale that. So there are some examples where there's some very very good evidence of various programs, but I'd have to say some of ours is trial and error. But we are committed to measuring and change and not waiting too long to do that.
So I think for Medicaid agencies, it is a combination of making sure you're staying on top of it. So if you put something into place and it doesn't work, that's your evidence base. But also there are a number of groups and efforts that are doing academic research or private sector research, and a state will hire them and find out what kind of works, or talk to private sector partners on the evidence side. On the resource side, in about 2 weeks, we'll put out a report that we do every year. It's a survey of sort of operational challenges and issues in the Medicaid program and Medicaid leadership. And it's showing an increasing dedication of resources within agencies, often existing resources being rechanneled, but sometimes new resources from grants and other places, to delivery system and payment reform. And then increasingly in that same context around data and analytics and getting better at that. But it is in many ways a cobbling together, and I think that's a real challenge for us, is that if we don't dedicate the resources to doing this right, it is a real problem, and opportunity fatigue will become failures. And I think that we can't afford that, and I think that agencies and Medicaid directors are really trying to get their agencies to be more operationally effective so that when they put these things into place, which they are trying to do, we know that they're working and we can oversee them.
The thing I would just add is for those of you who would want to engage and support, and I mean
Yes.
and support, instead of engage and convince.
Yes.
If you want to engage and support, your Medicaid folks, your state employees folks right now are having to make decisions with less than 99.99% certainty. So do we use the academic research wherever it is applicable? Yes. Would we value the academic input so that it's a 51% decision instead of a 50-50 decision? Probably so also.
Absolutely. Yeah.
Great. So why don't we open it up for questions? Do we have microphones? See, who's working them? Yeah, we got a couple microphones on either side. Yeah, and if you could introduce yourself and your affiliation, please.
Sure, Mark Stabach with Alkermes, my own. I guess I want to, it's primarily, I guess, for Joe and Kathleen as it gets to the state, and I'm going to interpret value a little more broadly because most of the discussion is about, what a benefit structure or a copay is like, and of course in Medicaid that often doesn't apply. So we work in substance abuse and mental illness, and so when we talk to governors, they have a very different view on the value because the heroin epidemic, for instance, is a healthcare cost, but it's also a criminal justice cost. It's Department of Children and Family. It really cuts across these areas. And so I'm just curious if there are opportunities for benefit design or payment reform or other types of programs that you see at a state level that don't strictly fit well, here's the copay, this and that, but can, and I could repeat the whole questioning over again and say, now let's substitute serious mental illness and schizophrenia and talk about criminal justice. And just curious what you see as possible.
To be honest, I think that Chris's point about states being the central focus, and I used to work for the National Governors Association, so sorry if I show state bias there too, but they don't think only about what happens in the healthcare budget. And if you look federally, HHS thinks about these budgets, and the committees of jurisdiction at the Congress think about those budgets in those ways. And so we know at the state level that if you put pressure one place, it almost always blows up. And a lot of the heroin epidemic right now is coming because we've been trying to control opioid abuse. And so we know that these things pop up when we don't come together. And so a lot of what happens is the kind of thing you were talking about, where a governor can take the agencies and hold them all accountable across their programs for doing things in a different way. And we have states that have worked on bringing foster care programs and getting the Medicaid program working next to the Child Protective, so that everything is moving in the same direction. And that can happen at the state level in a way it can't happen anywhere else, and has to, because we're accountable at the state level for all of those different moving parts. The serious and persistent mental illness issue and substance use disorders, I think, is a place where we're really going to have to step it up. And nobody really has all the answers yet, but there's a growing idea that we need to really get our arms around that whole thing and not just look at it as a healthcare issue, because if we do, we're going to miss some really important parts. Housing is one that we consistently talk about healthcare, but if a person doesn't have a place to live, their healthcare costs are going to be entirely in the emergency room, because that's where they're going to go every night to get sleep. So it's things like that we really have to come together around those conversations. I don't know, Joe, if you...
I would add, this is more from our perspective. For the last 10 years, we've tried to integrate data from different agencies to be able to make the value-based equation argument.
Yeah.
I don't think we've done a good job of being able to execute on the analyses or the resource. But, your point is well taken, and it's broader than the co-payment value-based discussions on benefit design. It is probably where multiple dollars with lots of commas are in terms of payoff. And so to the extent that argument can be made, how often after the discharge from a corrections department do we end up having a domestic abuse in the same family situation, and the agencies or divisions don't necessarily even know what the triggering event was until too far after the fact. I think there's a lot of value potential. Where and that trigger comes from, I'm not sure where the entity or the group is, that triggers the prioritization of those analyses.
Would you agree that they are, I think I heard Kathleen draw a distinction between policy challenges and management challenges.
I'm with, there's no energy behind it. I mean, I don't have any, I don't have any political energy behind crossing stovepipes now inside of state government. It's managing, we've got multiple crises going on inside of the healthcare space, which is under a complete transformation. So I'm agreeing with Kathleen in a slightly different way is, man, if I had a governor that came in and said, find me all the waste across divisions, as opposed to find me how to contain cost within divisions, it'd be a breath of fresh air. Is that fair?
No, that's good. I appreciate it. Yeah, absolutely.
Other questions? Here, and then we'll go to Joe.
Hi, Shannon Haffey from the American Medical Association. We've heard a bit of today from, I think, all the speakers about how providers should be engaged differently. So I'm interested in your thoughts on what call to action you would make to providers to be part of the solution, is part of consumer engagement, but also just in value-based insurance design.
You want to start? You want me to start that one? Or
You
want
go
to
for it.
Okay. As I said when I was talking, I really think that that is the core of getting there. And I think that any given individual consumer's decision is going to be mostly driven, and we know this, by what their doctor tells them. And if the copay is more, but the doctor's telling them it's important, that's what they're going to do, right? Provider engagement is both an essential component and really challenging. When we're talking about anything other than multi-payer like you are doing in Arkansas, where there's one coherent message all driving in the same direction across all the insurers, we're kind of doing a lot of one-offs, right? We're all talking to them about a different thing, and we're all trying to drive a different agenda. And it's really hard from a Medicaid perspective. Traditionally, we're the lowest paying payer. We pay for a lot of services and a lot of people, but we don't pay very much a lot of the time. So often the conversation starts with, just pay me what you owe me, and then we'll talk what I'm going to do differently later. So without other engagement, without cross-payer engagement, it's really hard to engage the providers, but I think absolutely essential for all of the kinds of reforms that we're talking about, and daunting for a lot of the provider community. This is a dramatic set of changes for them. And I don't think we've really got the best handle, other than the shoe leather that Joe and others have put into meeting with them, walking through their issues, figuring out how you can help them change, I think is really key. We've also talked about Health IT today, and that's another place where they're like, yeah, give me one more thing I got to do differently. And we haven't had as much success in that area, in part, I think, because we haven't kept in with that. But it's also getting them to the point where change is going to happen. And getting them to accept that is going to be a really important key step, because reform is happening all over the place, and they have to be a part of it.
The reason I wanted to go say, I think we've had a little more success than many across the nation for two reasons. One is we do have all of our payers with the same message. So we have harmony in message that I think our providers nationwide know change has to happen, but they don't have a harmonic message coming to them about what path it is that they need to go down. And they've gone down too many paths, a couple of steps, and then got jerked around going a different path 2 years later. So we've achieved harmony in message. The other that we did was for every single episode, we had a provider open public process to actually map what should be high quality care for the patient, to actually share with those providers what their episode looks like. Let me just tell you, when we put up for attention deficit disorder, the average by provider cost for simple non-comorbid ADHD therapy for 12 months, and for some providers it was on average $2,000 a year, and for some providers it was on average $12,000 a year, they start looking at each other. They're not looking at us as the bad guys. They're looking at each other saying, what are you doing here that is causing so much variation in price? I didn't say it earlier, but our construct was our episodes are going to narrow the variation so that we actually get high quality, efficient, narrow variation care when needed. Our patient-centered medical homes are going to be the clinical decision makers on when that care is needed. So we're dealing both with the variation and with the volume at the same time. And we've got pretty good provider, I mean, I was sharing at lunch, I mean, we have a meeting once a month with all three carriers, the Medical Society, and the Hospital Association for 3.5 hours, and then we have lunch together over payment improvement in the state. And I would have never told you 2 years ago we would have those groups in the same room at the same point in time in a harmonic kind of place. But it's getting they know they need to change. They're looking for a consistent message on what that change needs to be and a commitment to actually support that change to happen.
What's that line? You're either at the table or you're on the menu? Is that sort of the setup?
Well, we did have, just to share, we did have an orthopedic surgeon stand up at one of our public meetings and say, well, what if I don't want to participate in the episodes? And it was very helpful for the Blue Cross vice president to say, well, you don't have to participate in the episodes. But if you don't participate in the episodes, you're not in our network. So it is a condition of participation. I mean, that kind of, no matter where that person went, with the exception of Medicare, that was the same message they were getting for participation in our multi-payer effort.
And for us, the payment reform has been the missing piece, because we've tried to build in accountability at the member level, build in accountability with our payers, and for years have asked the provider community to step up. And you know, it's fragmented in Tennessee, so it was a big ask. So the payment reform initiative for us is that missing piece, and the data are what's going to make it successful, and the coverage in the market, having as many of the payers participating as we do have, which is key. And now again, getting the other self-funded plans interested as well. But going out to the market at the same time, so that the physicians are hearing the same message, receiving information that's useful and helpful, I think is critical.
I want to emphasize, each payer is paying different rates and having different incentives, but all of the financial incentives are aligned in the same way on every provider by each payer. So it's not a monolithic single payer, single rate structure. It's just that the financial incentives and quality incentives are all aligned in exactly the same way by payer.
Joe?
I think I'm loud enough. In any case, so I think the harmony idea is definitely right. You've got to get some sort of all-payer agreement on this, and to get doctors, and that sounds smart. And certainly in New York, that's what we tried to do with our Medicaid program, and a lot of states are doing, like Massachusetts. I guess the question is, and this goes back to also, if you get rid of 30% waste, if you're doing what you're doing, what about the hospitals that fail? You probably got, in New York, a state like New York, and I'm sure it's everywhere else, but a third of your providers are like, yeah, we're on the curve, we're ahead of the curve. A third are like, we want to be there, and another third are just like, we're going to wait for the next governor, and he'll fix it for us, or she'll fix it for us, right? So, and that hospital is in the poor section of Little Rock, or you're getting a lot of pressure for everybody's like doing what you want to do, but Vanderbilt isn't, and you're not going to have Vanderbilt in your network, So the political pressures, you got a lot of power, but you're also going to whipsawed, and we see it in New York. We had a closing commission. We got rid of a lot of unnecessary hospital beds. Now we have a gigantic federal waiver to right-size our system and do a lot of vertical and horizontal integration. And at the end of the day, someone's going to have to close someplace. And Susan Sarandon's going to be on the picket line, even though she never went to that hospital and never would go to that hospital, because that hospital should stay open. So, kind of, if there's 30% waste, it's happening. Somebody's waste is somebody's boat payment, right, or mortgage payment. So how do you mediate that, or is that down the road in your jurisdictions? But I think it's going to be there pretty quickly, and folks are going to leave the system, go out of business, and there's going to be that kind of disruption. And how do we mediate that disruption, or what are your thoughts there?
So, you said it was off base, but you're going to accelerate that in the 24 states who are not covering the poorest and most needy individuals for which there are resources available. So just I'm trying to play by the rules. There are going to be two sets of states, some of which it's going to be more and a faster issue than others. But it's still going to, I mean, our goal was actually not so much to reduce cost as much as it was just to get the growth in the system in alignment with the growth in either public or private sector revenues. I mean, our kind of mantra as we went out, and we asked, we went to 20 different provider organizations, and I'd ask the question, how many of you think there's 5% or 10%? And every one of them got to 20 or 30, some of them got to 40%. Of course, it wasn't waste in their membership that was causing it. It was somebody else over here. So your question is right on target. You know, for hospitals, we're going to be asking them to have a different business model. It's not going to be a volume-based business model for the most part. You may have some centers of excellence for which they can nationally market a volume-based, high-quality, screen out the people who don't need it, and I'll still have enough on volume to actually make it work. For the other hospitals, particularly, I think your academic hospitals with the reductions in research, so they're getting hit with a double whammy, are going to have to rethink their model. Our rural hospitals are going to have to expand. I didn't have a rural hospital that had a home health agency. Okay, let me say that again. I did not have a rural hospital in the state that owned a home health agency. Well, now as we start thinking about readmission penalties that came out from Medicare last week, I've got a hospital that had a 3% readmission penalty from Medicare. If they don't own a home health agency in the next 10 days, they should go out of business. I mean, you know, seriously, this is about a transformational market change that at its core is changing from volume to outcomes. And if you've been on the volume side of the equation, you should think that your business model is at risk and figure out how you get on the outcome side of the equation. And it may mean that you're outside of your walls. That's what we've done with our patient-centered medical homes. We're telling the primary care docs, they are your responsibility before they walk in your door and after you leave. Find your partner in the community that you need to be with. And some of it's going to be lay community providers that aren't licensed, that they're just out there knocking on doors. So this is huge transformational change. It is, I would just say, our message to the provider community has been, it's not business as usual. We've said internally, the governor's comment, 70 to 80%. We did not take this on as a pilot, or a demonstration project, or a temporary effort. It was full system transformation.
You know, I would add that your point about home health and the rural hospitals. I mean, in many ways, this is what happened in the nursing home industry, right? I mean, you know, we had lots of beds, and that's where everybody went. And as we've slowly moved this way, there have been nursing homes that have closed, and there have been nursing homes that bought assisted living and bought home health agencies and really stepped up. And I think I don't think we're going to move as fast as might cause cataclysmic closures across the state. But at the same time, we're moving. We are going to move. And people have got to figure that out and get on board and find their business solution. Mm-hmm. Did they really think readmissions would actually happen? Did everybody think that? I'm not sure we all thought that, but they are. So I think that's really, we're going to have to keep pressuring that message. But also watch, you know, there are conversations that are happening. The more we integrate, the more we see integration, are we creating our future monopolies and market behemoths that we're going to have to deal with? Yes. Okay, well, let's deal with that when we get there. So I think that that's something we always have to keep in our minds, that we can go too far the other direction potentially, but we have to keep moving.
Two important groups in that conversation, I think, are state legislators, because that's where they'll go, and governance. It is the responsibility of governance, and to a certain extent, they need to be held responsible for that. All right,
I might just add, I think in your you're going to have states that did and didn't expand, so that's one dichotomy. And you've got densely populated areas and rural areas, and that's a big dichotomy that offers different business models, and one size is not going to fit all four of those quadrants.
Okay, Mark's circling. I'm going to steal a page from Cliff. It's January. The new governors come in whatever state. Kathleen, you pick a state. You've got one line off the record, your advice to the governor. One sentence.
You
I'm
go
pointing
first.
to you.
Yeah, it's pointing to you.
Well, first of all, unless I'm in Massachusetts or Oregon, the governor's not going to come ask about changing health care.
Well, I've said that he does, so I'm going to
Okay,
so the governor's here.
So the governor's here. I would say when you have our next crisis, let's make sure that we put value into the solution and don't just go for cost containment.
Great job, Governor. Full steam ahead.
Very wise.
Sorry.
I'm being facetious, but I mean, we are working on payment reform. He also has an initiative that's really statewide around health improvement. He is focused on these.
You're likely to have the same governor. I definitely will have
I will have the same governor. So good job, Governor. Full steam ahead.
Kathleen?
Yeah, I think that from my perspective, staying in the Medicaid arena, I would say really help your Medicaid agency engage in the reform effort through support for business intelligence and competitive contracting and value driving skills in your Medicaid agency to keep what's already been highly successful, whatever it was in that state, reform efforts going.
Great. So, round of applause for our panel.
What an amazing day. The VBID Center is just so happy to be part of these conversations, and I think we're pretty true to our soundbite of changing the discussion from how much we spend to how well we spend. I think this panel really exemplified that. I want to thank all the speakers and moderators again. This was really incredible. Also, the sponsors, which are listed on the back page of the program, I yet to distinguish them out. If it wasn't for them, we wouldn't have this amazing meeting and most of the activities of the center. All of you attendees, and the attendees, some of them who had to leave early, I think came from over 30 states, and I know you're all busy, so very much appreciated. Just before I send you on your merry way, a couple things specifically about the Medicare Advantage RFI. This will be easily accessible on our website and elsewhere. I think this might just elevate the conversations, even if you're not interested in Medicare. It might get you thinking more about value-based insurance design and the role it might play in your own institution. You'll find this information on our newly redesigned website, vbidcenter.org, or just Google VBID. We passed Vehicular Borne Incendiary Device, as many of you have heard, in 1999, so you'll find us very easily. Please recycle your name tags on the way out, and do me a big favor and say goodbye and thank you to Susan Lynn Osterly, who has worked for weeks, 7 days, 16 hours to make this all happen. And I just want to make sure that everyone knows that this meeting would nowhere near be anywhere close to a success if it wasn't for her input and the rest of our staff. Safe travels, and please feel free to contact us at any time. Thank you all very much.